Okay, so we have begun.
Welcome, everybody, to the second part of our webinar series, the OU ECP, the New Emerging Career Professionals Department, together with jscreen. It's really such an important space here that we're creating. This webinar is entitled Egg Freezing and Fertility Preservation, Experts and Experience. It's so important to acknowledge how significant the world of women's fertility has and continues to expand, and that we continue the education within the Orthodox Jewish community. It's an honor and privilege to introduce our panelists today, Dr. Joshua Klein, Chief Clinical Officer at Extend Fertility, Sharon Pollack, the Genetic Counselor and Educator at jscreen, and Jordana Brown, the Fertility Preservation Advocate. There are going to be 3 short presentations from each of our panelists, and then we will have a panel conversation, and at the end, a chance for an audience Q&A. So without further ado, it's an honor to introduce our first presenter, Dr. Joshua Klein.
Thank you so much. You hear me okay, right? Okay. So it is my pleasure to be participating. This is a topic that is definitely near and dear to my heart. I am a fertility doctor in general, but I have a particular interest in specifically this topic, fertility preservation. And the way I usually try to approach kind of laying out the subject is really to break down the background first, rather than jumping into, what temperature are the eggs frozen at, or what needle do you need to use for the medication? Because I think that laying the groundwork of why this is even something that women would potentially benefit from learning more about and potentially pursuing, I think helps inform the decision-making process. Because at the end of the day, egg freezing is a really powerful technology. It can, and today already is, kind of changing lives in a really amazing way that's very gratifying for me to see. But it's not for everybody, and it's not, not everyone has to do it. And so I think that a better way of approaching the subject is to kind of get clarity on the background of why you might want to consider egg freezing, and then you can be better equipped to make a decision if it's something that you really should look into. So I'm going to share my screen because I have a bunch of slides that I'm going to walk through together. Sorry, there we go. And okay, I'm good on the slides. Yeah, oops. Okay, so a bunch of years ago, at this point, probably about 10 years ago, I came up with this gumball analogy to try to help illustrate how it is that egg freezing can be something that helps people achieve their goals in terms of their family planning goals. And the idea basically is that by far the most common reason that women would consider freezing eggs is because they know they may want to have children later. They aren't ready to have a child now. And they know that something happens biologically to every woman that will make it more difficult and potentially more unlikely for them to have children at a later date. And that's what people, are going to refer to as the biological clock or reproductive aging. We use a lot of different terminology, but the basic idea is that age is not our friend when it comes to fertility, and specifically female fertility. I do want to take just a half second and say men are not completely absolved of this topic. There are some things that happen to men's sperm as they get older in terms of the health of the sperm. But at the end, and without getting into that, at the end of the day, it is important to recognize that the severity of the effects of age is much, much more on the female side than it is on the male side. And that's why this topic does live much more on the female side of the equation. But again, it is also important to say that men are not completely spared from the effects of aging when it comes to their fertility, and we can talk about that separately. There are some women who decide to preserve fertility for specific medical indications. Some of the more common ones would be if a woman is, God forbid, diagnosed with a cancer and needs to undergo chemotherapy or sometimes radiation therapy that can be damaging to eggs. that can cause an artificial premature destruction of eggs that can be circumvented by doing egg freezing in advance. But again, the day to day, by far the most common story is a woman who does not currently find herself in a situation, whether it's she doesn't have a husband or doesn't have a partner of any sort, or for one reason or another in her career and her education is not ready to start a family, but again wants to keep the options as much open as she can to have children. And that, of course, means having at least a child, but especially in the Jewish community, many families will want multiple children. And so even if someone may not have difficulty having one child, but if you think in the sort of play the long game and thinking, when am I going to be up to my third or my fourth or my fifth, which is often the case with a lot of the Jewish patients that we talk with, it takes time. It takes at least a couple of years to have a baby. And so if you're first starting your family in your mid-30s, that's not necessarily a terrible time to start. But by the time you're ready to have maybe a third or a fourth or a fifth child, you're going to be in your 40s, and that can be much more difficult. But I want to lay out basically this paradigm here. So essentially, the age-sensitive ingredient in the female reproductive system is specifically the eggs. What I mean by that is, if let's say a woman is 45, which is not a great time to be trying to have a baby, and she wants to try to get pregnant. It's not happening so easily, which would not be surprising. She might come to a guy like me and say, I want to have a baby. I'm 45. Can you help me? And I'd say, well, we'll do IVF right away. That's our most powerful treatment. And if she says back, well, I've heard IVF is really expensive and it's a complicated process. Can you give me a realistic sense of the success rate? Well, the reality is that no matter how great the doctor might be, or no matter how great the lab might be, the success rates of IVF for women doing IVF in their mid-40s are universally very poor. Very poor means like less than 5% chance of success per try. So that is kind of at this stage, an undisputed reality that even with the most powerful and technologically advanced abilities that we can offer in this day and age, having babies in your mid-40s is difficult. Can it happen? Yes. Is it something that we can feel confident relying on? If we're talking about strategizing for the future, the answer is definitely not. But if that 45-year-old woman has an egg that is younger, whether that's her own egg that she froze when she was younger, which is what egg freezing is all about, or until egg freezing became a realistic option, what used to be done more frequently and still is done quite frequently is getting an egg donor. So in other words, a woman in her 20s can donate eggs, and then the woman in her 40s can fertilize those eggs with her partner, have a fertilized egg, or what we call an embryo, returned to her uterus, to her womb. The chance that that works is actually quite good. So the idea is that the statistics of success when it comes to fertility follows the age of the eggs. It does not follow the age of the body. And so that's how egg freezing becomes a strategy, is that if, for example, 32-year-old, Rachel or Sarah or someone freezes her 32-year-old eggs, and 42-year-old someone wants to have a baby, and maybe it's her first, but maybe it's her second or third or fourth, the chance that we'll be able to make that happen is more like 32, which is not 100%, but is pretty good, as we'll get into in a couple minutes. It's more like 32 than it is like 42. So it's like you're transporting your present day potential of fertility and putting it in your pocket to pull out of your pocket when you need it, maybe 5 or 10 or 15 years down the line in the future. What this slide with the gumball machines illustrates is what is happening to the eggs as you get older. Meaning what I've basically been saying so far is that the age-sensitive ingredient is the eggs, which means that the eggs change as you age. So in what ways are the eggs changing? And the answer is there's two main aspects of this process biologically. One is a change in the quantity of the eggs remaining, how many you have left. And the other is a change in the quality, the health of those eggs. One of the reasons why I think the gumball analogy works is because if you look at the graphic, so as you progress from a younger ovary, which is filled with the gumballs and is mostly the non-shaded gumballs, there's two aspects, right? There's a lot of them, right? The high quantity, and also most of them are non-shaded, which in this graphic is representing genetically intact eggs. Most of the eggs are normal. As a woman ages, two things are happening in parallel. One is that eggs are dying every day. So there's fewer and fewer eggs remaining in the container, in the ovary, as it were. And second is of the eggs that remain, more and more of them are becoming genetically broken, genetically abnormal. Genetically abnormal eggs are not viable in the sense that they are not able to lead to a viable pregnancy. Now, keep in mind that the natural system is that women ovulate. They naturally release one random egg per month. And there's two parts to that statement. It's just one and it's random. And so the way that the egg quality affects the chances of conception is that a woman, let's say in her 20s, who has a very high percentage of normal eggs, like that gumball machine on the left, if you turn that little knob at the bottom and let one randomly come out in any given month, which is basically what's happening, there's a high chance it's going to be a good one. So if you have 90% normal eggs in any given month, it's a 90% chance you're going to get a normal egg to work with. Or over the course of 10 months, on average, 9 out of 10 months, you're going to get normal eggs. That, in a nutshell, is the main reason why fertility is supposed to be, for most people, not all, but for most people, fertility is an easy thing in your 20s because you're getting lots and lots of good opportunities. Every normal egg that arrives is another good opportunity. And almost every month, you're getting a normal egg because most of what you have is normal. But by the time a woman gets to her 40s, the vast majority of the eggs are genetically abnormal. And so if you turn that knob again once a month and let one random egg come out, the vast majority of the time, if let's say 80 or 90% of the eggs are abnormal, which is the reality for women in their 40s, then it's an 80 or 90% chance that the egg that she gets each month is going to not represent a good chance for pregnancy. And no matter how careful she is about all the other stuff that people sometimes worry about, timing of intimacy and being healthy in general and eating the right foods and doing exercise and keeping stress levels low and all those things, they do matter in their own way. But at the end of the day, if the egg of the month is not a good one, which is most of the time, it's not going to lead to a viable pregnancy. And so that's why built into this reproductive aging system is the silent reality that it gets more and more statistically difficult to encounter a healthy egg to be able to have a viable pregnancy as a woman progresses through her 30s and then into her 40s. Okay. I want to emphasize two more things on this topic. One, let's see where we should go. One is this: no test exists for egg quality. So the concept of egg quality that I'm talking about is basically this idea that it represents a percentage of your existing eggs that are either normal versus abnormal. And we know that it is driven exclusively by age, which is to say that everyone in their 20s has mostly genetically normal eggs, and everyone in their 40s has mostly genetically abnormal eggs. There's no exceptions to the rule. It doesn't or it isn't driven by a woman's overall health. Like even a woman who's in her 20s and is not a healthy person, doesn't eat healthy, doesn't exercise, overweight, she's still going to have mostly genetically intact eggs. And the opposite, unfortunately, is also true. Women in their 40s, even if they're doing all the right things from a general health perspective, most of their eggs are unhealthy. We know that from the last half century of IVF, but what we can't do is test the eggs, right? So if I meet a woman in the office and she's 36 years old and I say, well, I think that about half of your eggs are normal and half of them are abnormal, which is true. And they may say back to me, well, can we just check that or confirm that or test that? The answer is no, we cannot. We know that age drives this idea, but there actually, even today, there's no test for egg quality. And not only is there no test for egg quality while the eggs are still inside a person, there's actually no test for egg quality even after eggs are removed to be frozen. So this graphic is just basically saying the same thing that I was saying verbally. Women in their 20s, the vast majority of the eggs are normal. Women in their 40s, the vast majority are abnormal. Women in their 30s, it's a transition stage in between. But one of the things to know about egg freezing, which we'll maybe come back to in a few minutes, is this idea that we actually don't know if the eggs that we are freezing are genetically intact. And that's part of why numbers play a big role in the topic of egg freezing, meaning we don't want to rely on freezing just one egg at a time because we can't know if it's a good one. And if we only freeze one and it's not a good one, obviously it's not going to work out well in the long term. But if we can get 5 or 10 or 15 or 20 together, the chance that we at least have some good ones in there is very, very high. And so that's why numbers are a big part of the conversation around egg freezing. Okay. The other thing, which I'll just return back to quickly, is this idea that while age is the only determinant of egg quality, so there's no relevant testing. For the other side of the story, egg quantity, there are tests that can give us a pretty good picture of where a woman stands. Not everybody in their 20s has a very high egg supply, even though most do. And not everybody in their 40s has a low egg supply, even though most do. There is individual variability. There are exceptions to the rule. We do meet women in their late 20s or early 30s who actually have a low egg supply despite their young age. We do meet women in their 40s that actually are lucky and have a high egg supply despite their reproductively older age. So anyone who looks into this topic probably will quickly bump into AMH. AMH stands for anti-Mullerian hormone. It's a hormone that is, to keep it simple, it's a reflection of the egg supply. So basically, if a woman has a high circulating AMH level, it's a simple blood test. It's not very expensive. You don't have to be fasting. You don't have to be at a certain time in your cycle. So you could get this through a fertility clinic, but you can get this through a OBGYN or even potentially a primary doctor. And basically, the AMH gives us a pretty good idea if your egg supply is on the higher end or on the lower end. And just to illustrate that, I don't know if you can see my cursor, but if let's say someone is listening to this talk and they say, well, I'm only 29 years old and, I get it that age matters, but I'm only 29, so I'm fine. And hopefully they are fine. But I will say that on this graph, you can see there's 3 lines. There's the red line, which is the 10th percentile, which means out of 100 random women, 10 women will have the red values and below. The green line on top is the 90th. Out of every 100 women, 10 women will have the green line and above. And the turquoise line is obviously some representative of something like average. But if you're a 10th percentile 29-year-old, that means your AMH is going to be about 1.5. That's the average level for someone who's 41, right? So if you are unlucky and your egg supply is low for your age, you might be walking around at 29 thinking everything is great, except that your egg supply is more like a 41-year-old. Now, quality is not like a 41-year-old. It's an independent issue, but that obviously can be something that can be very helpful to be aware of. And there's only one way to know it. There's no symptoms. It's only something that you would find out by testing. Of course, it can go the other way too, right? If someone here is listening and they're 42 years old and they're panicked, well, 42 quality is always an issue. So there is what to think about and what to be strategizing about. But if you're blessed with a good egg supply, if you're a 90th percentile 42-year-old, your AMH may be 3 or 4, which is actually average for someone in their young 30s. So you might not need to be panicking as much as you are. And you just, again, you don't know it unless you get tested. So AMH is a simple blood test that can tell us a lot about where a woman stands relative to the average for her age. Okay, I'm going to skip. Can IVF save the day? We already kind of treated that topic a little bit. In general, the success rates of IVF for women who are doing it in their mid-30s and younger are quite good. But for women doing IVF in their 40s, it's quite poor. That's sort of the dirty secret of the world of IVF. IVF is a really incredible, powerful treatment, but it does not work well, even today, for women doing IVF in their 40s. As you can see, this is some nationalized data. For women doing IVF at the age of 43 or 44, the chance of success is just over 5%. For women doing IVF at over 44, the chance of success is under 5% per try. Whereas those strong blue bars represents women doing IVF at those ages, but using younger eggs, right? Donor eggs or potentially frozen eggs if it's their own. So IVF cannot save the day from an age perspective unless you have younger eggs to work with. And then I just want to spend the last few minutes of my section here talking a little bit about success rates, right? Because I've been doing this for over 10 years now, really heavily focused on egg freezing. And 10 years ago, we actually didn't have as much data as we do today. And that was one of the most common questions is this just like a fad that, it's a business and people come in, freeze your eggs, it's a cool thing to do. And then, we're not going to have any benefit from it, or can we expect that it's going to work? And so I'm gratified to be able to talk about egg freezing success rates because at this point, we now have lots of data to show whether egg freezing is something that can work. But the key idea that I want to project in this discussion is that there's no simple answer to whether egg freezing has a good success rate because it completely depends on 2 main variables. A, the age at which the eggs were removed and frozen, and B, how many eggs we have to work with. It's like the analogy would be, is it difficult to get into medical school? Well, if you graduated from, I don't know, some unknown college and have a poor GPA and a very low MCAT score, it's going to be nearly impossible to get into medical school. If you graduate from an Ivy League college and have a 4.0 GPA and, have a great MCAT score, it's going to be very easy to get into medical school. So the answer to the question is completely different depending on the circumstances that you're asking from. And so what you see in these graphs, this is data that's actually not our data. I'm going to show you our own data in a moment, but this is data that was published a bunch of years ago. And what it's trying to illustrate is the following. In the top left, you have a graph that represents women who froze their eggs in their young 30s. If you freeze between age 30 and 34, and then if you look at the graph, on the bottom of the graph, you have the number of mature oocytes. That basically means eggs that the woman froze. So if you are a woman who's in her young 30s and you freeze a good number of eggs, let's say about 20, the chance of being successful, meaning that you could have at least one child from those 20 eggs, runs about 80 to 90%, meaning very high chance of success. Whereas if you are young, but you only freeze a few eggs, let's say you only freeze 5 eggs, even at a younger age, that chance of having a baby from those eggs is only about 40%, right? So each egg is a ticket to potential success. The more you have, the higher your chances of success are going to be. And the other layer here, of course, is age, right? So a woman who is in her 40s, if you go to the bottom right graphic, a woman who's in her 40s, if she freezes the same 20 eggs, which is not easy for someone who's in her 40s, because that's the double whammy problem, is that as you get older, more of your eggs are bad and it's harder to get a lot of them. So quantity and quality converge to become a double problem as a woman progresses through her 30s and into her 40s. But for argument's sake, if it's someone who had a really good egg supply and they got 20 eggs, you're still only looking at a less than 50-50 chance of success with 20 eggs, because each of those eggs is more likely to be unhealthy and therefore less likely to work. And so, and if you freeze only 5 eggs in your 40s, you're only talking about between a 10 and 20% chance of success. So the idea is that these two variables, the age at the time you take out the eggs, is reflective of the likelihood the eggs are healthy, and that's one main driver of success. And the other is how many tickets in the game you have, how many eggs you're able to retrieve, because the more opportunities you get out when you freeze the eggs, the more likely we're going to find a healthy one to be successful, and potentially more than one to be successful. Here is data that is hot off the presses. We just published this paper. It was officially accepted for publication in the last month or so. And let's see what I want to just highlight here. So one of the things that we're proud of, if you look at the all ages, for all for women who of all ages who have frozen and then unfrozen eggs with us, the survival rate of those eggs is about 91%. So a little bit more than 90% survive. That's actually quite high. No one's previously published survival rates that are that high, and we're proud of that. And then you have what we call fertilization rate and blastulation rate. I won't get into that because I think we're short on time. But looking more simply, this is our own data from the Extend Fertility Clinic in New York. So for women, all the women who froze at younger than age 35 and then came back to use their eggs, regardless of how many eggs they had, our success rate is about 81%, meaning 4 out of 5 women who froze eggs younger and then came back later were able to have at least one baby, and some will have more than one baby. Some have had more than one baby. Women who froze between the ages of 35 and 37, that success rate is about 75%. Women who froze between 38 and 40, that drops down to about 54%. We don't have a huge number of women who froze over 40 that have come back to use them, so that's why that's not included in this graphic. And the other graph that you see on the right here is looking at the number of eggs available. So if you look at all comers, meaning anyone, this is for all patients, again, who froze under the age of 40, or including the age of 40, actually, less than or equal to 40. For any number of eggs, the overall success rate was 70% for all patients under 40. But you can see how it moves with the number of eggs available. If you freeze over 20 eggs, you're over 80%. If you freeze less than 10 eggs, you're under 60%. All of these numbers are still pretty good, over 50-50 in every way you look at it. But again, there's no doubt that freezing younger and freezing more drives the statistics of success in the direction that we want it to go. And this is just a little bit more detail there. I think that's the last thing about the data. Now, in the last 2 or 3 minutes, I'll just make a quick comment about process, right? So all of that is hypothetical. Why would someone want to freeze their eggs? In what way can it help us manage the reality of the reproductive aging or the biological clock? And so now just to touch on for a moment, what does that really mean? How do you freeze your eggs? So the way we do it at our clinic, which every clinic is going to be a little bit different, but it's going to be some version of the same idea. So the first step is people get information, right? They basically get the AMH blood test drawn. We usually do an ultrasound to take a look at the ovaries if possible, and that arms us with the data points to have a more informed conversation. The second step is the discussion with a doctor. The third step we call logistics class is basically to prepare the patient for the realities of how to get through egg freezing, which is basically learn about the medications. The medications that get eggs to grow do not come as pills. They only come as these little tiny injections. They're not some giant scary needle. They're really, really a tiny needle, but they are injections. And so there's a lot of needles involved with a process like this. And so we basically do a class with a nurse to go over the different medicines and how to administer them. And then once a person has gone through that, they're ready to do the monitoring, which is about 10 to 14 days of intermittent ultrasounds and blood tests. So it's a lot of blood tests and a lot of ultrasounds. It's not every day for 10 to 14 days. It's usually about 5 or 6 or 7 quick visits in those 10 to 14 days. And then there's the retrieval, which is the procedure, which is done with the anesthesia to take the eggs out. And then the eggs are isolated and identified and processed in the lab immediately. And within a few hours, they're vitrified, which means basically frozen and then stored. So this just gives a little bit more of a detailed version of what I just said. I won't get more into detail here, just in the interest of time. But essentially, the idea is that you do some basic testing, you come in to talk to us or to whoever the doctor that you want to talk to, and then when you're ready to do it, the whole process takes about 2 weeks. It's nightly injections for about 8 to 12 nights, followed by a procedure which takes about 10 minutes under anesthesia. The procedure is not invasive surgery. There's no cut, there's no incision, there's no stitches, there's no scar. It's basically a very thin, long needle that is passed transvaginally when the patient is asleep, and it goes directly into the ovaries, and that's how we extract the egg. So there's no again, scar or stitches or anything, and people are basically back to their normal routines usually the next day. Okay, those are my slides. I'm going to end my screen share. We can always come back to if someone has a question about it, but let me get rid of that. And I'm going to hand over the microphone.
Thank you so much, Dr. Klein, for really such an impressive, informative presentation. There's so much to take in. We very much appreciate your time and your expertise and sharing that with our webinar today. I'm excited to introduce Sharon Pollack, the genetic counselor from jscreen.
Thank you so much. I'm just going to quickly share. Okay. So my name is Sharon Pollack. I'm the genetic counselor or a genetic counselor at jscreen, and I also do outreach and education. And the topic of today's talk is genetics and reproductive choices. So if you joined us for the last webinar that I was a part of, this will be a little bit of a review for you today, but in either case, I am going to jump in with just a little bit of genetics 101. So we talked so far a lot about egg freezing, and we want to talk a little bit more today about what the testing is that could really play a role in fertility preservation, and also what testing might be like most appropriate for someone who is going through that. So just to jump in here a little bit, within every cell of our bodies, we've got an identical set of instructions called the DNA. The DNA is essentially a very long code by which the body grows, develops, and functions, and is condensed on chromosomes, little packages of DNA that come in pairs. It bears mentioning here that exactly half of that DNA arrives in the egg from our mom, and exactly half from the intended father, from the sperm. And when combined, an embryo is created. Now, we've talked a lot about the egg freezing process, but of course, eggs to ultimately become a pregnancy would need to be combined with sperm, and that's really what we're talking about here today, is that full complement of DNA and what testing might be appropriate on an embryo, ultimately a blastocyst. So we'll get there in just a minute. Now, when you zoom in on the chromosomes, what you'll see is, again, this long strand of DNA, and different segments of DNA are called genes. Every gene is going to have its own function, telling the body to create a certain protein, hormone, or enzyme, something that's keeping the body healthy, functioning, and well. I'm going to talk a little bit about what testing jscreen provides access to. And so jscreen is a nonprofit that provides access to two different tests. One is something called reproductive carrier screening. This is what we're going to be talking most about. But we also provide access to something called hereditary cancer testing, which is a panel of more than 60 genes that we take a look at to see if there are any mutations within those genes that we know can increase a person's risk of cancers. This is actually valid because I think, and worth discussing today, because when individuals do know that they are carriers for mutations within these genes, there are some reproductive implications ultimately, as in people will sometimes decide they don't want that passed on to the next generation. And we do have tools to actually bring that to life. But for the most part, when we as genetic counselors are counseling patients about PGT, pre-implantation genetic testing, and its connection to embryo creation and ultimately fertility preservation, we're usually talking about reproductive carrier screening, and jscreen provides access to a test like that as well. It's a panel of over 260 different genes where we know when both partners, so both male and female partner, are carriers for mutations in the same gene, there is then a reproductive risk for their offspring to inherit that condition. And so what we're taking a look at with reproductive carrier screening is to see if there are any mutations within those genes, but primarily if both partners are actually carriers of mutations in the same gene. And let's talk a little bit today about who should have this kind of testing, where it's accessible, and when is the most appropriate time to access that testing. So for who, we always like to very much emphasize that it's for anyone considering a pregnancy and not just their first. And so what we find very typically is that there's a misconception that people say, well, I've already had this testing done and I'm kind of in the clear. Maybe they already have a baby that was healthy and they feel like they don't need this testing redone. That is actually frequently a misnomer. Sometimes they've actually had only very limited testing. Sometimes the testing was actually good quality testing, but it was done a long time ago. And while genetics don't change, our genetics are sort of fixed from the moment of conception, the genetic testing does sometimes change and can be updated in order to reflect updated risks that a person might then be able to know about going into a future pregnancy. So that's a really important piece to emphasize, I think, as well. Where is this testing accessible? So jscreen provides patient-initiated testing. So all you would have to do is visit our website in order to access this testing, but we also run community screening events. And I'm going to be speaking about one that we're doing in conjunction with the OU ECP later this month at the end of this talk. So if you happen to be in New York, you'll have your opportunity to actually go in person, which is great. This sort of testing is also available through a genetic counselor, although we're not available as much as you think, but as well in physician offices like Dr. Klein's office, where the testing is certainly encouraged and offered there as well. And the most important question, I think, for today is when is this testing offered? And you'll notice I bolded before because that is certainly our preference, but during a pregnancy as well. But what I'll say is that when we test before pregnancy and we know about the potential for a carrier couple and the potential for affected offspring, our options are really much more broadened, I would say, than if we know about the potential for a baby being affected during an ongoing pregnancy. So that's why we really encourage this testing to be performed before. And I'm going to pause on sort of that line of thinking for just a moment to correct what I find are typically the biggest misconceptions, I think, when patients are hearing about this carrier screening for the first time. And so they say to us typically, well, I don't have any family history of this condition. And we like to remind patients that about 80% of babies born with an inherited condition are actually born to parents who have no family history of the condition whatsoever. So unfortunately, it typically comes as a surprise and not a good one. And in our experience at jscreen, about 75% of the people that we screen are carriers for at least one condition. And that typically comes as a surprise because patients tell us, well, I'm completely asymptomatic and as far as I know, totally healthy. And that's actually kind of the point, is that individuals who are carriers of mutations within what we consider autosomal recessive genes basically means that they would have no symptoms. And that's why this testing is so valuable and so important, is because we would have really no other way of knowing that this is a risk to a patient or to offspring without the testing itself. And when we do find that we have identified a carrier couple, some of the things that we'll mention as options are the potential for not having children, although that's not what we're recommending, perhaps choosing not to pursue a particular relationship, adoption, gamete donation, which would basically mean either an egg or a sperm from a non-carrier to be donated to that couple in order to be used in a pregnancy, the possibility for natural conception with testing after the pregnancy is already ongoing. This is also kind of the way we need to go about things when testing has occurred once a pregnancy has already been achieved. But the big topic today is really going to be talking about in vitro fertilization, which refers to the combination of egg and sperm outside of the body with pre-implantation genetic testing, which I will henceforth be shortening to PGT, which refers to the testing of the embryo itself to identify, is this an embryo that contains the mutations we're concerned about, or does it not? And so this slide actually just quickly represents what testing early on might look like. At the top, which I'm not going to focus on as much, talks about chorionic villus sampling or CVS and amniocentesis, which basically accesses DNA from the baby, the growing baby itself, to see is this baby affected by the condition of concern. And on the bottom, you'll notice in vitro fertilization with pre-implantation genetic testing. And I'm going to explain a little bit more about that in the next slide. But before I do that, I just want to very quickly mention something as follows. So there are sort of like the three main ways that we want to think about the inheritance patterns of the conditions that we're most frequently testing for. And on the far left, you'll see autosomal dominant. This would refer mostly to the conditions that we're identifying on the cancer screening panel. Now, if an individual knows that they're a carrier of a particular mutation, they have a specific condition, this kind of testing can be appropriate for them as well. But as far as the testing that jscreen provides access to, most of the conditions that are autosomal dominant are going to be the ones that appear on the cancer panel. But that also, again, plays a role in the potential for PGT, because some individuals will opt to sort of break that line of inheritance for increased cancer risk by using this technology, which again is not a magic pill, but really is an incredible tool when used correctly. On the right side, you'll see the autosomal recessive inheritance and X-linked inheritance. Autosomal recessive inheritance is kind of what I've been referring to up until now, where both partners would need to be carriers for mutations in the same gene in order for there to be a chance for affected offspring. Whereas X-linked conditions are conditions that women can carry, where they would be at risk of having affected male offspring. And for both of these conditions, PGT may be appropriate. And I really felt like I wanted to mention this really quickly because I think one of the things I hear frequently when individuals are hearing about PGT for the first time is that they're saying, well, this turns out to be such an involved process, which I'll get into in just a second. So why do I even need the testing in advance? And the answer actually is that we need for this technology to actually know exactly what we're looking for. And I think that that's a piece of the puzzle that sometimes people miss. It's like, this seems like such incredible technology, and it absolutely is. But when it comes to specific mutations that we're looking for, so in this case, PGTM, so pre-implantation genetic testing for a specific mutation, that mutation has to be identified in a specific gene and in a specific family in advance of this sort of testing. So what is this PGTM process that I keep referencing? So we'll start at the top left of the slide where you'll see what is actually an egg. So either perhaps it was a frozen egg, perhaps it's a fresh egg, but ultimately needs to be combined with sperm for now the complete complement of DNA. We leave those eggs in the lab those embryos in the lab to develop up until day 5 or 6 until they become what we call blastocysts. And you'll notice that there's actually this ball of cells in the inside. We call this the inner cell mass, as well as the outside, which is ultimately going to become the placenta, but is for now called the trophectoderm. And it's representative, usually, of what's going on in the rest of the embryo. And so if we pop off a couple of these cells on the outside, at this point we have to remember this is not a baby's arm or a baby's eye or a baby's leg. These are just cells that can then reproduce, but they are representative of what this baby will ultimately turn into. And so if we save those cells and we test those cells for the presence or the absence of the mutations we're most concerned about, we can get a sense of whether an embryo is normal, is a carrier, would be affected. But I do want to pay attention to the fact that sometimes we don't have any result. The end goal here, though, would be for a normal embryo or a embryo that would be unaffected to be selectively used in the transfer process with the hopes of achieving a pregnancy. And that's kind of the whole PGTM process and the testing process there. I just want to very quickly mention that our mission at jscreen is to really transform the landscape of genetic testing by allowing access to this testing patient initiated. And if you are interested in this testing, you can request a kit at jscreen and use code OUECP for $18 off today and going forward, and you would receive your saliva sample kit in the mail. And you just have to return it to us. Ultimately, you'd be able to access genetic counseling services from our genetic counselors at jscreen. And I just wanted to quickly show this in case you want to screenshot this, and it will be available online as well. But this is an upcoming screening with the OU on January 27th at the Jewish Center in Manhattan. And if you do have any questions for us, please input them into the question box. We'll be answering them later. And thank you so much for coming today.
Sharon, thank you so much for that really informative presentation, for all you do together with jscreen. And it's an honor for us not just to hear from you, but also to partner with you to have in-person screenings and have kits available to be sent directly to people's homes through jscreen for genetic testing as well as hereditary cancer screening. It's my honor to introduce Jordana Brown, the fertility preservation advocate, who's going to share with us her story. Thank you, Jordana.
Hi, everyone. I'm coming to you from Israel. I'm sorry, that's why I look a little tired. It's past my bedtime. But I just wanted to talk about my experience. I actually froze my eggs twice. The first time was when I was 33, and the second time was when I was 36. So when I remember very distinctly, and this could be relatable to certain people, but my reason for freezing my eggs was because I always knew very, very clearly that I was going to be a mother one day. And I always assumed that it would be the mainstream way, that I would get married in my early 20s, that I would have my first child in my early 20s, and then I would proceed to have the rest of my children in my 20s, and then maybe into my 30s. When I found myself still single in my mid and upper 20s, I kind of realized that, maybe life wasn't going as planned. When I started thinking about egg preservation, I don't know that it was as common and as widespread, but it certainly wasn't never done. And I think that I grew up in a modern Orthodox community. So I grew up, Sabbath observant and mitzvot observant my whole life. And it certainly wasn't like something that all my friends and I decided that we were going to do, when we were 18, 19 and going to get married and have babies. And for the most part, my friends did get married and have babies. But then, as the shidduch crisis took hold of the community, it became apparent that there were a lot of really wonderful women who were desirous of having children, but kind of time was running out. So I basically made in my mind a timeline, and I said, if I am still single by X, I'm going to look into freezing my eggs. If I'm still single by Y, I'm going to look into using those eggs. And so I remember my first benchmark was when I was 32. I still was single, and I decided that I really, really wanted to freeze my eggs. I live in Israel. I grew up in New York, but I live in Israel now. And one of the things that I'm very, very grateful for is that egg freezing is much more affordable in Israel. IVF actually free in Israel for up to 2 children, but egg freezing is not. It's elective unless medically necessary. So I knew that I was going to have to pay for my egg freezing procedure and the medications that come with it. But I knew that it was going to be somewhere between a quarter and a third of what it costs in the United States. And with that in mind, I was also thinking, okay, maybe I'll do it more than once. So the first time I did it, I remember that I was really, really angry that I'm a very God-fearing person. So I was very angry that I had to do this because it wasn't fair and nobody else had to do it. And why couldn't I have just had babies the regular way? And so I was a little upset that I had to do it. I cried, I remember the first time. And throughout the process, I'm not scared of needles. I'm not scared of, anything invasive, really. So when I had to do my blood testing, my blood work every other day, when I had to give myself my injections every other day, these things really didn't bother me. But I understand how it's difficult for other people. And so I always like to, kind of hold the hand of anyone that it's hard for. And the first time I did it, I remember that the relief that I felt once it was done was incredibly palpable. I remember just being so relieved that I took care of my own fertility. I took hold of my own fertility. I took hold of like my own future, so to speak. I felt like for such a long time, in the Orthodox community, a lot of emphasis is put on whether or not a woman is able to have children. And it's basically like, men, like the doctor was saying, that men think that they can all, produce children into their 80s, whereas women become, somewhat useless after 40. And I never wanted myself to feel like I was anything less than just because I was getting older. And so once I had those eggs in the freezer, I was really, really relieved. I actually went to a fertility preservation class, and I said to the lady, I've frozen my eggs. So what are my chances? And she said, well, if you want to have more than one child, you should freeze again. So I remember 3 years later, I froze again at 36. And then I had a number in the freezer. Actually, it's in 2 different hospitals in Israel. So I've had to travel. And you go from basically, having these eggs in the freezer, but they don't really mean anything to you until they actually did mean something to me. And not to get it, because this is an egg freezing conversation, but I was going through the process of having a baby. And I was doing IVF, and I wasn't in my 40s when I was doing IVF. I was doing round after round of IVF because I mentioned it was covered in Israel. And I was doing one round after another, and I was not in my 40s. I was in my late 30s, and I was not getting good eggs, and I was not getting a lot of eggs. My fertility basically dropped off a cliff. I had one round where I garnered 11 eggs, and then in my next round, I garnered 3. And only I think 8 months had passed or something, and it was like tragic and horrible. And I was going through round after round, and one of my doctors, he said to me, I think you really need to start using your frozen eggs. And thankfully, these eggs that I had frozen in my second round, because I still have my eggs from my first round, they all thankfully multiplied, and they all became embryos, and one became a baby, thank God. And so when people, I hear a lot of really people poo-pooing it and saying, frozen eggs doesn't equal a baby. And I can't say that every frozen egg, I mean, we just heard the statistics. So obviously not every frozen egg equals a baby, but I certainly know that I feel very, very grateful that I took that into my hands. And I know that I have a lot of friends. I mean, when I meet people any woman over 30, I will always, always ask her if she's frozen her eggs or if she is interested in it. And a lot of people think that it's really invasive, and I understand where they're coming from. But from me, it's coming from a place of love, because if a woman wants to have a baby, they cannot just assume that everything's going to work out. Very, very often things work out. But I think it's so important that a woman has some say in her own future and in her own fertility. And a woman takes her own, destiny, so to speak, into her own hands, because otherwise we're really leaving it up to God, which is a very beautiful way to live. But I don't know that every single woman can live that way. I think a lot of people really need to feel like they have some hand in their own future. So I'm a huge advocate. I mean, I don't know that it's my official name, but I am in a lot of, helping groups, and I do give a lot of information to people. I have, an Instagram account where I talk about my egg freezing process. I answer a lot of questions. People, I like to say I talked, 20 people into freezing their eggs, but it's not a hard thing to do. I mean, there are definitely obstacles, and I can't say for every single person that the results are going to be the same, and I can't promise anything to anyone, but I can say that from my own experience, it's been nothing but good.
Jordana, thank you so much for sharing from your own personal experience. You were referencing about you can't just rely on Hashem, but obviously the work that Dr. Klein does, really, it's godliness. It's Ratzon Hashem of utilizing technology together with women who put themselves out there with the guidance of incredible organizations like jscreen and genetic counselors like Sharon to be the hands, to be the kli, the vessel of Hashem to help people on their parenting and fertility journey. Each of you have shared such powerful insights today. So I want to ask each of you on the panel, what is one message of hope or empowerment you want every person listening today to take with them? Dr. Klein, let's start with you.
Thank you, first of all, and thank you. It was really interesting listening to all the other panelists. And Jordana, kudos, and that's a great story, thank God. And yeah, there's more and more of those stories, I think, out there now. I think that, from my perspective, one of the key points, and someone even touched on this, I think, during this session, I think there's a psychological barrier for some women to think about freezing eggs, in the sense that it feels like something of an admission of defeat. That the plan A, which was, like Jordana said, get married, have kids in your 20s, and just do things the sort of the typical way. I kind of lost out on that, and so here I am stuck with this in a doctor's office with needles and injections and spending all this money on egg freezing. And I can of course understand where that comes from, but I think the flip side of that, which I think is probably the more accurate way of looking at the story, is that we have this technology, and as Sarah just said, it's God got to put there for a reason. And if someone is freezing their eggs in order to keep their opportunity to have the family that they want in the future open, I mean, it's literally, you couldn't get further from an admission of defeat than that, right? Meaning you're doing something proactively that takes a lot of effort and costs a lot of money to be strategic and be thoughtful and be proactive about planning for your future. So I think that the mindset of egg freezing is, kind of is an end game bad thing. It's not the end, right? It's hopefully just the beginning. And like I keep saying over and over, because I'm almost like amazed myself that we see so many of these women who froze 5-10 years ago are coming back and having babies. And it may not have been possible for them to have those babies, without those frozen eggs. So I think it's a mindset issue of egg freezing is something you do, not because you necessarily clearly have to, but rather because you want to take charge of your destiny, like Jordana said. And I think it's a really powerful way to frame the conversation.
Thank you. Thank you, Dr. Klein. Sharon?
I think that I would really just emphasize the importance of community. We talked a little bit about this before everyone else joins, but I think that conversations like these are so important because it removes a little bit or chips away a little bit at whatever taboo is left around egg freezing. And I think that having the social support is something we as genetic counselors talk about so frequently. But for this to be something that can be in the mainstream as a conversation, I think will allow people to not experience the decision to freeze their eggs as everyone else is sort of saying, as much of a pivot as it sometimes I think is framed as. It's an insurance policy. It's something that you can do to empower yourself, to secure your own future. And I think at jscreen, we're very focused on patient empowerment and patient education, and that's what we're trying to do here today.
Thank you. Go for it, Jordana.
No, what the doctor said actually just like rang a bell for me, because I remember thinking that there were hundreds of years of women being called whatever it was, a spinster or whatever you want to call it, someone who basically had to give up the opportunity to be a mother or to go on that journey at a certain age. And now we are living in the age where it's accessible and there are ways to do it. And I know that it's sometimes cost prohibitive, but I would tap into any savings you have or loans you may need, because I really do think, as Sharon said, it's an insurance policy. And as much as you get insurance on anything else, this is an insurance on your future, an insurance on a future that you want and that you see for yourself and that you can attain.
Beautiful. Thank you. Thank you so much to each of our educated, passionate panelists sharing professionally and personally. There are so many resources available within jscreen through genetic testing and cancer hereditary screening, as well as education like this webinar about egg freezing and so much more. And with the Orthodox Union's Emerging Career Professional Department, we are here to facilitate physical, emotional, and spiritual health. So it was amazing to be able to come together to share this information. And if we could encourage anybody listening to, whether it's to schedule a consultation, getting tested, or sharing what you've learned today with people that you love in their lives, that's something that they could integrate, think about, and put into action. We feel so blessed, both jscreen and ECP, to live in a time with such a vibrant Orthodox Jewish community where we're not scared or we don't shy away from these conversations that really can change our lives personally, but also to create future generations of the Jewish people. So thank you once again to the panelists. Thank you for everybody for listening. And thank you for being here.